Typically begin with, what do you guys have? Okay, you have passive flexion, passive extension. What do you guys have in the middle? C. Active extension to the splint and passive flexion. C. C.
No, we went with B.
Oh, I
You have-
had C, they had B, I guess.
Okay. And what do you guys have? C. So we wouldn't want to do passive extension with the flexor tendon because that could rupture. So D is absolutely out. We would not do A and D. Like with the NBCOT, the best strategy that I recommend students is cross out the two that don't make sense, right? And then between the last two that are left, pick the one that your gut tells you to go with and that is the most typical and that doesn't violate anything involving safety. Okay? So the most typical answer would be C. You could do B. If you had a dynamic doctor that was letting you do early active motion.
That's what I thought it was before the 7th day. So
Yeah.
The 3rd day, that's what I thought.
But I can tell you, if you cut your tendon in Grand Rapids, Michigan, there's no doctor here that's gonna, I mean, if I knew the doctor and I said, I'm gonna do an early active protocol, they would let me, but for the most part, you're gonna be doing a passive protocol, unfortunately. In a perfect world, I would want to do B with all of my patients, but that's not what happens.
So C's the most right?
C is the most right. B is not wrong. You could do B. B is not wrong. But in this world, in Grand Rapids, Michigan, we're doing C. Or in Kalamazoo. If you're from Kalamazoo too, it's the same conservative physicians there as well.
Now, does the active extension not rupture the tendon because pain stops them, or it actually?
Not, pain should stop them too, but the splint is gonna not let them go all the way up.
That's
Yeah, that's the key. So number 3, what did you guys in the back get? D? D, yep. 12 weeks before you can do sports or any heavy work. Moving furniture, that kind of thing, Number 4, an extensor tendon injury at zone 3 is known as central slip. What'd you guys get? Central slip, central slip, central slip, central slip. Okay, yep. Okay, number 5 is kind of these trick questions. And I'm trying to take all these out of my test slowly and surely. An appropriate activity for a patient with flexor tendon laceration that is 6 weeks post-op would be, what'd you guys put? There's no fear in this class. E. E, which is B and C. So,
A and B.
Oh,
I'm sorry, it's the wrong, I was looking at the wrong question. Like I said, didn't want to say.
okay.
B.
B, paper crunches to increase tendon glide. What does the middle group say?
We said F.
F, B and D, paper crunches to increase tendon glide or dynamic extension splinting.
we said E.
E, paper crunches to increase tendon glide and you said the same thing as that.
No, so they had
Oh, you said F, static night extension. What about you guys?
We had that.
Same thing, paper crunches and static night extension splint. That's correct. So we don't want to do putty.
What's correct?
F is correct. We don't want to do putty because that would be resistance. And when can we do putty with tendon repairs? What week?
8.
Week 8. Yeah, week 8 before we can add resistance. So we know that A is out. Dynamic extension is resistive too. It's going to be putting force into extension. So too early for that too, which leaves the static night extension splinting if they have a flexion contracture and paper crunches to increase tendon glide.
So I was just reading this like, the board question. where it says static extension splitting due to flexion contracture, it said like risk for, so I thought that you know what I mean? So I thought this person had one, but it wasn't. I don't know, does that make sense? So it's like, there's not like.
Not everybody may have a flexion contraction.
Right.
But for those that do, you could do it.
Okay, but it's not just for risk for.
Right, right. You could also do ultrasound at this point at 6 weeks. Sometimes the doctors will let you do it early if you're not gliding well, if you're not doing well, ultrasound. Where we use thermal ultrasound to create a deep heat, and then you follow that with active exercise to try and free that extrinsic healing, free that tendon from the surrounding scar tissue.
I have a question.
Yeah.
So with dynamic extension splinting, so if my patient has a flexor tendon laceration, so they can't actively flex the tendon, so they should still be able to extend it.
Sometimes they can't because the scar is so forceful, it's holding them flexed, and they can't straighten all the way because it's stuck.
The scar from surgery? Oh, okay, so that's why you're doing dynamic extension.
But you wouldn't do that early, you do static
Static
extension.
extension.
Not less,
So it's to prevent, oh, okay. 'cause
it's
if
to
you
increase
say-
extension.
Okay, so it's to break up that scar, make sure the scar, or the extrinsic healing, is that what it is?
So whenever you do any kind of mobilization splinting, meaning dynamic, and we covered this in 4720 in my class, and those of you who took it in Kalamazoo heard my annoying voice over recording in 4720. I recorded lectures on the PowerPoint. Did you guys have that?
Oh, wait a minute, yes, I remember.
Yeah, that was me.
Because we got a handout too, but.
Yeah. So to do mobilization splinting, we use a low load of force over a long period of time to increase tissue length. The same thing as the ear gauges do, right? If the ear gauges, you take it out and put a little bit bigger ear gauge and a little bit bigger ear gauge. That'd be like serial static splinting, where you make a gutter splint and you have them wear it, and then you take it off, you make it straighter, and then you have them wear it. It's like the ear gauges. Serial static splinting. You take a static splint and you serially adjust it as the patient makes gains. Dynamic splinting, you use rubber band traction to push it. So an example of dynamic splint would be if I put something over my finger to hold this down, and then I pulled it up with rubber band going this way to pull it to straighten. That's dynamic splinting. The whole purpose does not break up tissue, lengthen tissue. The tissue elongates in response to the need, in response to the gentle pull of force. Okay? So that's what splinting does. It's all called, this whole family of mobilization splinting, to increase tissue length. Static progressive, if I used a cord like this instead of a rubber band that the patient can't then pull out of, that's static progressive splinting. Uses more force, more for chronic stiffness. So the whole term mobilization splinting, whether it's serial static, static progressive, or dynamic, is all to increase tissue length, because the reason why the patient can't move, they don't have good passive motion. It's not for tendon gliding issues or scar adherence. Okay? All right? So I know you guys can't go back and review that material probably, right? If you look on the PowerPoint with the industrial rehab, at the end of that, or it was somewhere, on the amputee PowerPoint, there was some information about progressive splinting. So just go back and look at that. Okay, was that on the amputee? Somewhere we covered it.
So you're saying that dynamic splinting is better for chronic stiffness, like
Static progressive.
that?
Mm-hmm. Yeah. Okay. All right, number 6. The main goal when treating tendon lacerations is to, what did you guys put here in the front?
E.
E, which is A and B. Protect the repair, obtain tendon glide. E, 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 E. That's correct. So we don't want to increase strength, right? That's not our goal. And we can't prevent sutures from loosening. That's between the doctor and the suture technique, right? We can't do anything to prevent that. We can prevent gap from occurring. But that wasn't one of the options, right? Okay, with extensor tendon lacerations in zone 5, you would splint, what did you guys put in the back?
B.
B, 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 B. Yep, all the tendons. And why do we have to do that? What's the anatomy, the juncture? Yep. When the patient has a zone 1 extensor tendon, you would, what about you guys in the back?
B.
And one girl, sorry. Although they kept calling us lads in Ireland, it's like we say you guys, you know, and it just seemed weird to say lads because we're girls, but you guys. So you guys have B?
Oh, yeah.
Yep, that's correct. Splint the DIP joint, keep it splinted continuously for 6 to 8 or up to 10 weeks. But 6 to 8 is most typical. Extensor tendons are naturally weaker than your flexor tendons. True, we just said that, right? And number 10, you're treating a flexor tendon 4 weeks post-op. The MD orders are to splint in a dorsal blocking splint for 6 weeks, initiate active range of motion at 4 weeks post-op. At 4 weeks post-op, you have the patient perform flexion with place and hold, and the patient is able to make a full fist actively. What would you do? What about you guys? C?
C.
B.
B? C? C. So with B, it's provide a home program. If they're doing really well, we want to hold them back, right? So that means when they can make a full fist the first trial out, man, you're doing good. We got to hold you back, right? So we're not going to move them from place to hold to tendon glides. That would be increasing the force. That's moving up the pyramid, right? We want to hold them back if they're doing too well. We wouldn't certainly want to do putty, and we wouldn't stop the splint. Those would be all things that would advance the patient. If they're doing well with tendons, we hold them back. If they're doing poorly, we move them forward more quickly. So the correct answer is C.
Yeah.
So I might only have them do active motion in the clinic, and then free them up to do some more at home later. I'm holding them back. Okay, so we need to cover all the information about arthritis, and we have an hour and 10 minutes, so we gotta move on, all right? But a lot of the stuff, like, do we really need to cover mallet finger and swan neck? You guys know that. Do we really need to go over what a boutonniere deformity is?
They talk about relative motion splitting.
We don't need to go over that. So some of it's going to be going through this pretty quickly. There's only 43 slides, so only 43 in an hour and 10 minutes. But some of it we're going to go through. There's a lot of pictures, so no worries. Okay? So I'm just going to pull up the definition of arthritis. Destruction of joint surfaces that result in stiffness and inflammation. Aubrey, do you have your marker with you today, or should I go get one? Aubrey's our class supply person. So your I'll throw it. I will not catch it. I'll blame it on the light in my eye. So, and I'll wash it because I have this weird bug. So before I give it back to you, I'm gonna desensitize. Your patients will think they have one kind of arthritis, and you look at them and you're like, this doesn't look right. I think they have something else. But we don't diagnose problems, and we don't argue with our patients about what kind of arthritis they have. But it's a completely misinformed thing. people say they have rheumatoid, but they have osteo, people don't understand it, and that's not what they do for a living, right? They do something else, and they're an expert in something else, so it's not our responsibility to clarify that. I mean, you can educate them and show some things, but we're not gonna debate, right, with patients about what kind of arthritis they have. But basically, no matter what kind of arthritis they have, they got problems with their joints, right? They have inflammation and they have stiffness, okay? So basically, there's the rheumatoid family of arthritic problems, which we're gonna go over first. And then we have the old standard osteoarthritis, okay? So these are within this rheumatoid family, the systemic lupus, scleroderma, and psoriatic arthritis. They're all in this rheumatoid factor, this rheumatoid family. And then osteoarthritis is separate, okay? So with rheumatoid arthritis, this is an inflammatory disease that is systemic. It's not just in that one joint, okay? If someone has rheumatoid arthritis, it's autoimmune in nature. It's not just in that one joint. What happens is they have destruction of their synovial lining that leads to damage to the soft tissue that's around the joint. So when we think of what soft tissue is around the joint, that's the kind of things that provide the joint stability. So their joints become less stable and they're inflamed. So one thing that I want to mention is that we never do forceful splinting, like dynamic splinting or static progressive splinting with patients with rheumatoid arthritis because their joints are not stable because of all the disruption that is present from the inflammatory condition that is autoimmune in nature. But one thing, so one thing that's pronounced with rheumatoid arthritis is the MCP joints are most commonly involved or most commonly the first to present. So when people say they have arthritis, you'll look for these types of symptoms to see, well, what am I looking for? What do I see? And does what I see match up with what they're telling me that they have, okay? And when I first started working as a hand therapist, I saw lots of gnarly hands with rheumatoid arthritis. I'm meaning inflamed, contracted, deformed, deviated, non-functional hands. And now, 20 years later, I don't see hardly any, unless they're very old people, because we, doctors or scientists or researchers, have developed some fabulous drugs that are out there that are addressing these issues. And I would see people all the time with joint replacements along the whole MCP, usually one a month when I first started working. And we would have to make this kind of a detailed splint. They'd have to have a night splint, it's a very specific protocol you follow, detailed surgery, high risk. I haven't treated anyone with an MCP replacement, I know for sure, since I moved to Michigan. Because the drugs are preventing the destruction. And it's funny because one of the faculty that I was working with in Ireland, she's just finishing her PhD, her whole dissertation is on rheumatoid arthritis. And I didn't want to say, like, we don't even see those patients in the US anymore because all the drugs, but I wanted to ask her, but I didn't want to offend her study. Because maybe in Ireland, because of socialized medicine, those expenses, because they're very costly drugs, maybe they're not readily available to all the people in Ireland. So maybe they're still seeing all this huge joint destruction that we no longer see in the US. So I don't know, but she's just finishing, so she hasn't defended her her product yet, so she's not completely done, but her whole product is on this diagnosis that I really don't even hardly see anymore. So it's kind of strange. But the thing to note, MCP joints, most commonly involved, okay? Incidence, women more than men, and huge onset in difference, right? 20 to 60, huge variation in onset of the disease. There's specific deformity that is correlated with rheumatoid arthritis that is not correlated with osteoarthritis, okay? One thing is volar subluxation of the carpus on the radius. So by that, I mean, by the carpus, I mean the carpal bones. So if my hand were like this, my carpal bones would be down here. This is not an anatomically correct drawing, okay? And my radius is up here. My carpus dropped volarly. Volar subluxation of the carpus. What goes across here?
Extrinsic extensors.
Extrinsic extensors. Fabulous. Yes. What do you think could happen to those extrinsic extensors? So here's my EDC, right? If my carpus dropped volarly, what is this creating?
Is it stretching?
It's creating like a cliff. And if this rubs back and forth across the cliff, what's going to happen? Pop goes the tendon, right? So from this volar subluxation of the carpus, you could have tendon laceration on the extensor side, okay? What else happens is the MCP joints or MP joints, you get an ulnar drift. So has anyone seen anyone with rheumatoid arthritis with an ulnar drift? And their fingers go, that would be west, right? They go west, okay? They drift ulnarly. And what also happens is the wrist goes the opposite direction. I'm going to show you a picture to show this, okay? And then we also know, we already know what swan neck and boutonniere, but those are formed as a result of a central slip and a mallet finger. Because remember we talked about this inflammatory autoimmune destruction of soft tissue around the joint. And that can be from destruction to the tendons, destruction to the ligaments that surround the joint. You can have this bony prominences that the tendons ride over top of that cause the tendons to rupture, okay? So what causes that swan neck and boutonniere is the tendon ruptures, and then that leads to this deformity. Another thing that can happen is dorsal subluxation of the ulna. So when you think of this was my radius, but my ulna then can go dorsally, and my carpus already subluxed volarly. Now I got a big cliff going across there. Ulnarly. So pop goes my EDQ, pop goes my EDC to my long, small finger, pop goes my wrist extensor on the ulnar side. And if one tendon starts popping, there's another one that's going to be right behind it. So you have to be really mindful of that. You can also have big thumb deformities that occur. You can get a boutonniere or a swan neck deformity in the thumb. And then this tendon disability, which is what I'm describing, where the tendon pops as a result. So here is this zigzag deformity where the wrist moves radially at the CMC, the carpus, and the MCPs go ulnarly. And you get this zigzag deformity with rheumatoid arthritis. Again, in my opinion, if you saw a young person with this today, either their medical insurance didn't cover the meds that are out there, or they couldn't take them because of some organ dysfunction or something, or they're going to be probably over 75. and the meds weren't available when they were in their diagnosis phase, and they didn't have the opportunity to take them. If you see people with this now, they're going to be usually quite old, and the meds weren't available. And things that we can do you guys see, it's kind of hard to see, but do you see this, the head of the proximal phalanx here? It actually dumped off the side of that metacarpal. Do you see that? Can you see the shadow here? Here's the end of my metacarpal. This finger is off the side. And then what happens is the extensor tendons flap over the edge. They ulnarly sublux too, and they start to flex the fingers. Then they get stuck in this. Has anyone seen anyone really, like maybe an older person with really advanced? They'll flex, move the fingers into flexion, and they'll have like a shelf up here. It looks like almost. It's really destructive. But they'll get this zigzag deformity. So we can splint this if it's passively correctable and it's not painful with passive correction. If you cannot passively correct it easily, do not force it. All you'll do is create a deformed hand that is now painful. Okay? So by passively correctable, I mean I can just passively take the fingers and move them back over. Because there's lots of splints then. So think about it, if my fingers are headed west, my thumb cannot oppose anything for function. It probably can't write, cut vegetables, use a fork, brush their teeth, all those kind of things are probably really challenging for them because their fingers can't oppose to their thumb because they're facing the wrong direction, right? But if you can neoprene splint them up back to neutral, then you put their fingers straight and they can oppose again. But if you can't passively correct it, don't try. Or if you passively correct it but it's painful, no. If you passively correct it and it's like, oh my God, this is fabulous, then go with it. And there's lots of different prefabricated splints that you can utilize for that purpose, that you can order through Patterson Medical or North Coast or Orifit, any of those companies have tons that are out there. Some more rigid than others. You'll see some that, some people get a really forceful contracture as it progresses, so you might need some splinting orthoplast material to hold them up there. If it's pretty early, a neoprene strap, just pulling them over to move them back up will work. Okay? Sometimes I would like to put them in a resting hand splint for night and putting them back up in neutral to prevent the deformity from progressing. And here's a big thing is, my whole career I haven't gotten referrals from rheumatologists. They don't send their patients to hand therapy unless when I worked at the U of M, I got referrals from rheumatologists. Here in Grand Rapids, I didn't. When I worked in Ohio, I didn't. When I worked in 2 different areas in Florida, I didn't. So otherwise, rheumatologists, they use meds to treat their patients. Even though there's research out there, the evidence supports that splinting prevents further deformity, decreases joint inflammation. This is something that we've proven that works, but the rheumatologists aren't paying attention.
They're idiots. They're like the worst specialty. I worked with them. I looked at a patient. They're morons.
Yeah.
They don't care about function. They just care about seriously.
Yeah.
Anyone who's going to be a rheumatologist.
So maybe you guys can help change that, because we have a huge place. Not that we would see these patients for 12 visits, but a couple of visits for maybe a splint or some activity modification. Because think of all the things that we do that promote ulnar deviation at the MCP joints. Try to think of an activity that forces MCP, ulnar deviation. Think of some things that we do in our life. Grocery shopping. What do I do grocery shopping then?
Grabbing the bag.
So grabbing the bags, and I'm lifting them in the car, out of the car, those miter bags, pinching my fingers, promoting ulnar deviation. Good. What else?
I would, really a lot when you're driving, if you're doing them,
A little bit with driving. What else? What about cutting with a knife? Pushes ulnar deviation. What about cutting with scissors? Ulnar deviation. Huh? Everything. Wringing a washcloth. Turning a faucet. Turning the door handle. The things are endless that promote ulnar deviation. So if I have a patient who has rheumatoid arthritis and is on the risk of getting this huge ulnar drift that can hugely impact the function of their hands, a little bit of education, right, could be giant. Change a couple of door handles, get an adapted tool to grab your bags from Meyer, or get a rocker knife, get adapted scissors, all kinds of things that could prevent the deformity from occurring. But the rheumatologists don't utilize us. They do not. I have had many appointments with rheumatologists attempting to get referrals, and I have been unsuccessful. So they don't see the need. Unless you're working at a big medical center where you work together in a more interdisciplinary fashion. I've experienced different things. Okay. One thing too, if you're going to splint, you don't want to push these up without also strapping these babies ulnarly. So you got to do both. You got to put a strap here to push the ends of the metacarpals ulnarly when you're pulling these babies up. You got to do both. You can't do one without the other.
So when they're like that in that deformed position, when you go to try to move them and it's not painful, but it's like really hard to actually move it, is that just passively when you move it, should it be easy, or will it always be hard to like position?
As it stays in that position, it gets more and more force. It adaptively shortens the soft tissue, so it gets harder to correct. The more force you would need in your splint. If it's forceful to move it up, a simple neoprene splint probably won't hold it up. It might be too far gone.
So we'll
Which is why rheumatologists should send people early before it gets to that point.
So we'll know if it's too much force just by touching.
Yeah. And it doesn't mean that maybe a night splint might decrease the force and then they could tolerate a neoprene splint. Because in the night splint, you're going to adaptively lengthen that tissue, and then they might be able to tolerate a neoprene splint for a day. So the MP joint deformity is ulnar drift, and then you get palmar subluxation, when those fingers drift all the way off the side, and then they move palmarly or volarly because the fingers are flexed. And here's a picture of a pretty advanced form where these have all drifted off and they're resting palmarly because the extensor tendons shifted over the edge and they flex the digits, and then you get this shelf at the MP area. That's too far gone. Too far gone. So these patients will get a mallet finger, right, that then leads to the swan neck deformity, which we already learned about this, right? And you already know what a mallet finger is, okay? For swan neck, if they do develop a swan neck deformity and it's passively correctable, you could use the oval 8 splints, the silver ring splints, those other splints that I pointed out that are made through 3-point products that are cheaper. You could try making your own. Boutonniere deformity, we've already gone over, right? This is what happens, okay? Or it can be this lucky individual, and they have both a swan neck and a boutonniere in the same hand. Right? This isn't by accident from an orthopedic injury. This would be rheumatoid arthritis. Okay? So, we talked about that ulna dorsally subluxing, right? Here, we already know that also the carpus, this is the radius, this is the ulna. I can't draw the radius to the end of the side. We already know that the carpus typically goes volarly, the ulna goes dorsally, then we have problems with tendon rupture. Across that shelf is what happens. Rupture of the extensor tendons, especially to the ring and the small finger. And if one tendon goes, the other one is going to be right behind them. They can't wait, 6 weeks for a doctor's appointment. They got to get in and see a surgeon. Hand surgeon. Rheumatologists can't fix this. Hand surgeon. Not general orthopedic, for God's sakes. Hand surgeon needs to fix this. Okay? Sometimes even ECU is the extensor carpi ulnaris. That's the wrist extensor. When that ulna goes dorsally, sometimes the ECU will rock over the edge or sublux over the edge when they move their wrist. I like to splint these patients it's called a Count R force strap. Count R force. So it's not the same thing as a counter force strap for epicondylitis. Count R force. It's through the company Alimed. I have no alliance with them in any way. But I like this strap. It's just a Velcro strap. They can have wrist motion. It just straps around the end of the distal, the DRUJ, the distal radial ulnar joint. And then you can put a foam piece underneath it that pushes that ulna back down volarly to get them in better alignment for Sup and Pro. It's cheap. It's like under 20 bucks. And they work great. Or if you can sew, you can make your own with Neoprene or something like that. I don't sew. But putting that foam any kind of foam underneath there, then can help push that down. You Velcro strap it down, and it gives the patient a more stable position for Sup and Pro. Works really well, decreases pain, makes them more functional. So your thumb can have all of these. You do not need to know all this for the test. We're going to cover thumbs later in a whole segment on their own, okay, because they're so important. But this is the typical deformity that happens with rheumatoid arthritis and osteoarthritis. It's actually the same. But thumbs, they can also get this swan neck deformity and boutonniere deformity in your thumb. And we already talked about in the last unit that we need an arc in the thumb. We need slight MP flexion, slight IP flexion of the thumb to make this arch for stable pinch. If I get a swan neck, unstable. If I hyperflex my MP and hyperextend my IP, that's not stable. We want slight flexion of everything to create an arch for thumb stability. And then this next picture just shows this development of a swan neck, right? And then what happens even worse is what happens here then creates a problem out here at the CMC joint. And as this force comes here, usually the proximal end of your metacarpal dorsally subluxes. And you'll see a big hump or lump. So everyone go home next time and check out your mom's or your grandma's hands. And you may see some of these types of things happen in the thumbs. You might also get deviation because of this destruction of the soft tissue. You lose stability at the joint, and the thumb may head west, right? So you could use an oval 8 splint if it's passively correctable, and it's not painful when you passively correct it. You could push that back up and make the thumb now opposable to the index finger for writing, for pinch tasks, closes the clock baggie, all those types of things. Otherwise, the thumb's going the wrong way for it to be functional. Are we doing okay? Yeah? All right. It also can cause destruction of the ulnar collateral ligament of the thumb. Again, we abbreviate everything, so we call it a UCL. UCL. You might get a script that says UCL injury, ulnar collateral ligament. And that's most typically they're talking about the thumb. So the thumb has an ulnar collateral ligament and a medial collateral ligament. Remember, ligaments keep joints from going the ways they should not go. The thumb MP joint should just bend and straighten, right? If the ulnar collateral ligament gets ruptured, then the index finger pinches against the thumb and the thumb goes west, right? They don't have a stable pinch. The thumb goes this way. So you can check it. I'll leave Shivani alone this time. And you can check it by just stabilizing the metacarpal and trying to deviate it. And it shouldn't go far. Some people are more loosey-goosey than others, so if you think, oh, she's kind of loose, I'm going to check the other side. You can even measure it with the goni and look for variance and differences. So, ulnar collateral ligament injury. The way you check is you would press, give it a radial force, push it radially. And if it moves too much, this is extreme, right? Then that ligament's not intact. It's also called skier's thumb because people ski and they are holding on to those poles and they fall, and the ski pole pushes their thumb radially, and then they have this. So if this is not repaired, this person will never have strong pinch. Because every time they go to pinch, the thumb will go radially. Okay? So if you get this patient referred for therapy and you deviated their thumb and the orders say strengthening, do you think that's going to make any difference at all? Can you strengthen or mobilize a joint that is not stable? No. So I always tell you these horrible stories, but I had a patient that came in. She was a CNA, a certified nurse's aide in a nursing home, and she had an incident where she was trying to hold a violent patient down. It was in a dementia unit, and I don't know what was happening in the whole big picture of it. But anyway, her thumb got caught in the patient's clothing, and when the patient moved, it pulled her thumb in this direction. So she went to see, they had like a work comp clinic, you know? So she went to the clinic, and they said, oh, you have a sprain in your thumb, and sent them to me for therapy. So I see the patient, and right away, I'm like, this patient has an ulnar collateral ligament injury. I could tell right away. It even rested in deviation, so it was blaring. It was screaming out at me, you know? And so I told the patient, I'm like, let me just make a quick phone call to your physician. You know, I'm concerned about the stability of your thumb, something like that. I called the doctor, and I took measurements with the goni to tell them the deviation at the MP joint, right versus left. I'm concerned about the integrity of this is not a hand surgeon, you know, so I can be a little bit more comfortable saying what I think. Like, I'm concerned about the integrity of the ulnar collateral ligament. Please advise, right? They called me back. I gave them the name of a hand surgeon that I recommended. The patient then, I didn't see her again, okay? And I called her and followed up later on, and she's like, yep, I'm having surgery. I'm seeing Dr. So-and-so, which was not the doctor that I recommended, but another physician. And I'm like, okay, you're being taken care of, you know. And so I didn't see her for a while, and then pretty soon she's back on my schedule. She comes in, and guess what surgery she had?
Only plug on the elbow.
Carpal tunnel release.
Oh.
Carpal tunnel release. And I was like, are you flipping kidding me? How could I spell it out any more than I did, right? And I said to the patient, I really am concerned still about the stability of your thumb, still complained about thumb pain. She never complained to me about having any numbness. And so finally, she went to the doctor that I recommended in the front end of it, after she had to get permission from workers' comp, all this big old deal. And by then, she had so much destruction at the joint, she needed a thumb fusion. So I can't express enough about referring patients to the right doc and getting the right care. And you know, sometimes you may think, well, these tests are hard, like I don't want to know all this. Well, if you're going to work with patients, it's our responsibility. If you don't know what an ulnar collateral ligament injury is and you're working in outpatient OT, you may not be working with a CHT. You have to recognize it. We are the upper extremity specialists. If you don't know what it is, the family doc's not going to know what it is. The work comp doctor's going to, and even if you tell them what it is, they still may not do the right thing. So it's our responsibility to know this kind of stuff, right? So study. Study, study, study. Do the best thing for your patients, you know? Okay. All right. Okay. Another thing, when I drew something a long time ago, I pointed out Lister's tubercle. Remember? Weeks and weeks ago when we talked about the anatomy, when the semester first started. Remember, here's our radius. And I was talking about this whole important thing, right? And I talked about if we have this and this situation, which is pretty extreme. What's this called? Ulnar positive variance, right? Well, you have this little bony prominence called Lister's tubercle, okay? And what goes through here is your thumb extensor tendon, extensor pollicis longus. With rheumatoid arthritis, this can rupture over Lister's tubercle as a prime thing that you see with rheumatoid arthritis. And how you would know if someone ruptures their EPL, it can also happen with distal radius fractures, but also with rheumatoid arthritis, is you have your patient put their hand on something flat, and you have them do retropulsion, or have them lift the thumb up off the surface. And if they can't do it, they likely have ruptured their EPL. And you may be the first person to pick it up, because it just kind of rubs back and forth, and then pop goes the tendon. You know, the patient may not even notice it. And then all of a sudden their thumb is not as functional. Their IP may still straighten, but they can't retropulse. Okay. So we're moving on down the line to scleroderma, okay? I have only treated one patient for scleroderma in my whole career, and that's when I worked at the University of Michigan Medical Center. Since then, I've never had a patient with scleroderma, which in my mind is a crime because they're out there and they have a huge need for OT. But they're managed by rheumatologists, who Aubrey says are idiots, right? And we have it on camera.
I'm okay with that. Let's have it on record.
Right. I would say that they're very resistant to OT. So, scleroderma is a disorder of the small blood vessels, okay? Causes degeneration, and it's an inflammatory, because it's still one of those rheumatological disorders. So this autoimmune response. The way that you find out these diagnoses is not through x-ray, right? If it's an autoimmune situation, you need to have blood work to have a positive diagnosis, which is the R factor, which is positive for the rheumatoid factor with arthritis. And even then, it's very difficult to get a diagnosis. It's not so easy to get it diagnosed in the early stages, till it's blaring at you. Women 4 times greater than men. This has a typical deformity that occurs with scleroderma. Lack of MP flexion, they lose MP flexion, and they lose PIP extension. So when you see this picture, they lose MP flexion and they lose PIP extension. Okay? This is the typical deformity that occurs. It's an autoimmune response which affects all soft tissue. So I'm talking ligamentous structures, I'm talking skin, all gets impacted by this. Degenerative changes, the skin loses its elasticity, and these patients can get sores on the dorsal aspect of their PIPs because it bumps into things and their skin loses its elasticity. They can get, like they call them ulcers on the PIP joints. They lose MP flexion, and then they lose DIP flexion. Their thumb gets an adduction contracture, and they can lose wrist motion. But why is not OT involved? I've only had one in my over 20 years of working in hand therapy, one patient. So I hope that if some of you go to level 2 in hand therapy, if you see a scleroderma patient, send me an email. And I always say this to my students in this class, and I haven't gotten an email yet. If you see a scleroderma patient, send me a message to make me happy. Because I would love to work with this diagnosis. And these are patients that we would manage over a period of time. Like they would come back for tune-ups. You know, you would give them education and exercise for home, and as their diagnosis changes, you adjust what you're doing for what they need now. But these patients need us with scleroderma. It's huge. Yeah.
So do you have a concern that if you're able to correct this, do you have a concern about like rupture and FDS? Does that tend to get shorter since they're...
No, because this doesn't happen overnight.
Okay. So
And we're not going to do anything forceful like crank and pushing it to rupture. We would do something slowly and like a serial static splint.
Okay, so the FDS in this case would get shorter.
It would likely get shorter, but we're not going to crank it to rupture it. We're going to
Oh, okay.
give it a low load of force over a long period of time, which will lengthen. But our goal should be to prevent this from occurring through exercise templates for splinting, for night splinting, padding on the dorsal side to prevent ulcers from forming or protect skin
Is that something they have to do the rest of their life?
the rest of their life.
Wow.
So here's some things. You don't want to do anything drying, no fluidotherapy that would dry their skin out. Their skin already has lost its elasticity. No drying agent. Moist, paraffin, love it, right? But these are the kind of things that we can do. You can make an exercise template for just MP flexion. And you tell them, if you get to a point where you can't get down to here, call your doctor and get a referral and come back and see me. It might not be for 3 years, right? But you've given them something to work at, to keep going, to push harder, right? That they can prevent this deformity from occurring. So if I had something else that I would want to work with, it'd be scleroderma patients. I just think it's a population that's not being given everything they could get from our services. Raynaud's is again a problem as a circulatory problem with blood flow. You can have patients that have scleroderma frequently have Raynaud's, but just because you have Raynaud's doesn't mean that you have scleroderma. So don't be worried about that if like your mom or someone that you know has Raynaud's. Doesn't mean that you have scleroderma, but patients that have scleroderma frequently have Raynaud's. What you want to do is avoid the cold. I just took my daughters on a college tour a few weeks ago, and it was freezing cold, and we're walking around Western's campus, and there's a guy in front of me, and he didn't have a hat on, he didn't have gloves, and I saw him and he put his hands up to cover his ears, and his fingers were completely blue and white. I'm like, okay guy, you have Raynaud's, I mean, You have to. Why would you not bring gloves to an all-day college walking tour? You know, but yeah, you gotta keep everything warm. Maintain your body temperature. Pocket warmers. Be smart. Avoid the cold. For sure, no smoking. No smoking in life anyway, but for sure if you have a circulatory problem, no smoking. Psoriatic arthritis is another one of these autoimmune problems, but these patients, again, they may not come for 12 visits, but they might see you, get splinted to learn how to manage their symptoms. They do fine, and then something might flare it up. Like I had a guy once that was a house painter, like he painted houses, not like painting, you know? So it's a huge demand on his upper quadrants, and he had psoriatic arthritis. And he would come back in every once in a while, and we would do some things to calm him down, and then he would be fine, back to work, happy, get his range of motion back, doing well. But these people have, can develop decreased range of motion if it's not addressed. And you can also have rheumatoid arthritis and psoriatic arthritis at the same time. So we're leaving the whole rheumatoid family, okay? But those are all that whole autoimmune rheumatoid diagnosed, not just with x-ray, with blood work. So when my patient tells me that they have rheumatoid arthritis, I usually ask them, how were you diagnosed? And if they say, well, I went to my family doctor, they took x-rays, and they told me I had rheumatoid arthritis, we don't know that that's true. We can't, it's not diagnosed through x-ray, right? We're not gonna argue with them, or, you know, but we're gonna know in our head what we're working with to treat them appropriately. Okay, now we're on to osteoarthritis, which most of us in this room will develop. Okay? I know I already have it. Okay, so this is a deterioration of the articular cartilage that causes joint destruction, osteophyte formation. Osteophytes are little bony overgrowths that occur at the joint. They can break off and become a loose body in the joint. So it's an overgrowth of bone that forms at a joint that is arthritic, okay? So the etiology behind this is wear and tear. It's a wear and tear disorder, okay? So this is, again, when patients develop osteoarthritis in their hands, do they develop weakness in grip and pinch strength? Yes. If patients are diagnosed with osteoarthritis and have weak grip and pinch, does it make any logical sense to give them strengthening exercises with putty? It's already wear and tear problem. Giving them putty is creating further wear and tear. Okay? So if I find any of you ever giving anyone putty exercises that have a diagnosis of osteoarthritis, you're in big trouble. Big, big trouble. And then you're charging them for it. So you're destructing their joint further, and you're charging them $142 a visit, right? Don't do it. It makes no sense. The reason they're weak is because of the wear and tear of their joint. So what makes more logical sense to treat it? Stabilize it in some way. Rest it. Adapt it. Yes. We don't strengthen it. There is one instance where you can strengthen. So if you have arthritis of the base of your thumb, we know that when we pinch, our first dorsal interosseous muscle is in full gear, kicking on force, right? Put your finger here on the side of your index finger and pinch, and you'll feel that first dorsal interosseous muscle kick in, right? Everyone feel theirs? I can strengthen my first dorsal interosseous muscle that would then logically take pressure off my CMC joint of my thumb. that could give me more pinch strength. And you can do it just with isometrics.